as you said, my project was around using discrete event simulation to tackle the long waits and the growing backlog for children requiring neurodevelopment assessments, so autism, ADHD, and comorbid. I'm from Oxford Health NHS Foundation Trust. So what's the issue? The service is not able to keep up with the demand. We're looking at Oxfordshire and Bucks, but also across the country, as illustrated in the figure, which shows the increasing number of patients still waiting for an assessment over the past 2 years. Moreover, the average waiting time has increased by more than 50% in the past year, with patients waiting more than 2 years on average. What impact does it have? The impact on patients is that children are not receiving the support required, which means a deterioration in mental state. Parents are expressing concerns and lack of support while waiting for an assessment. The impact of service is longer waiting times means longer assessments, and complaints impact on managerial time and team morale, and we are losing staff to the private sector. So I've split this in what do we actually need to know on the whole process. So first of all, we need to understand the current pathway, which was quite tricky. We then needed to identify where are the main bottlenecks, the long waits in this pathway. And then we wanted to, okay, so now that we know the main bottlenecks, how do we actually manage the ongoing demand, and what do we need to do in order to maintain a steady state and avoid a backlog from growing? And then finally, we know we already have a huge backlog. So in addition of keeping a steady state, what do we need to have in order to eliminate the backlog that has developed as a result of the ongoing demand not being met? So these are the 4 kind of areas we wanted to address. So the pathway on a high level is referral gets sent from GP. It goes to SPA, single point of access, will triage the referral to the NDC team, which is sends out the questionnaires to schools and parents. Schools and parents return the questionnaire. The clinician determines the complexity. If it's complex, there are several face-to-face appointments with specialists. If it's simple, sometimes there's just digital appointments. And at the end, it goes back to clinicians to feedback to parents, signposting, obtaining referral consent, and so on. So that's kind of on a very, very high level. Then we looked at, so this is the pathway in a more detailed level, which also shows now the 10% trimmed mean waiting time in days between the different steps happening. So I won't go too much into detail here, but one of the things we wanted to look at was there were issues around, well, there were some questions around how long does it take to actually return the questionnaire back from parents and schools. And actually that waiting time wasn't that big at all. As you can see, it's only 35 days compared to, other waiting times in the process. So we kind of wanted to first look at this section here. And so it's the section where the episode gets opened to NDC by SPA. And then it takes almost 2.5 years for the questionnaire to be sent out. So what we actually saw that on average 4 questionnaires get sent out per day, and it's actually an artificially induced wait because the problem lies somewhere down the line in the pathway, because there's just not enough capacity to address all the questionnaires if they send out hundreds per day or so. So by focusing on further down the line, the pathway, we would address this long waiting time here. So this is just what I said about the 35 days and the 648 days. So by focusing down the line here, we are actually looking at this pathway, and this is what we designed in the model. So just going back to the model, so we are looking at referrals with completed questionnaires arriving as 4 per day. So that's kind of the entry point of the model. And then appointments get booked, and we can see who is booking the appointments. In blue, we have the trimmed mean now in hours. And then we have the split if it's ADHD, autism, or comorbid. So if it's ADHD, for example, after the appointments are being booked, there's an average of 8 appointments that take place, and it lasts about 40 minutes. And after that, there is a final appointment with parents to feedback and then close the referral. Now, in all of these different sections, we identified who is actually doing those appointments. So for ADHD and autism, we have on average 8 appointments. For comorbid, we have 10. But the thing is that we have staffing, like we have the admins, we have lead clinicians which are non-comorbid. So these are lead clinicians who are doing ADHD and autism. We have lead clinicians who can do comorbid as well as non-comorbid. We have the second assessors who can do comorbid as well as non-comorbid. And we have second assessor who only can do ADHD. We also identified that out of those, for example, for ADHD, out of the 8 appointments, 60% are delivered by a lead clinician and 40% by second assessor. Sometimes they also deliver them together, but most in the data what we saw is most often it's the split is 60-40. Similar with autism, it's 70-30, and with comorbid 75-25. I wanted to mention that the model is a simplification of the real world. The pathway itself obviously is far more complex. There are several assumptions that I will go through later, which are simplifying the model. Right, so what changes need to take place in order to keep on top of the ongoing demand and see the patients within an acceptable time? So for this, I would like to demo the tool. Give me a second. Right. You can still see my screen, everything okay?
Yeah, that's fine.
Okay, great. So I thought I include in the tool just to show the model and the assumptions, first of all, because I think it's really important to actually have to be very clear on the assumptions. So I have summed up the staff whole-time equivalents, and I'm assuming the staff are spending 2 hours per day on appointments and are busy with other things, but at the same time. So all staff are at the same time spending 2 hours per day on appointments. And why 2 hours? That's what I saw in the data. So out of the whole data, spending actually just 2 hours on clinical appointment time. I didn't include any holiday or sick leave, and all staff are unavailable at the same time. There's also an MDT discussion that happens regularly for comorbid cases, which I haven't included, and I can go into detail later in questions why I haven't included certain things. But if I just run the current model as it stands, so here again, I'm repeating kind of the picture of the model, and I'm running it for the last 5 years, and I'm using 10 runs. We also used 100 runs, but we didn't actually see much of a difference there. So what are the charts showing here? So this is the whole journey time. So what I mean by whole journey time is from the moment they enter, the completed questionnaire gets returned, because that's our model. So from the moment the completed questionnaire gets returned to the moment the referral is closed. That's what I mean by whole journey time. And then I'm splitting it by ADHD, autism, and comorbid, and it's the waiting time in days, right? So with the current research that they have, the waiting time in days, which is kind of similar to what we are seeing in the data as well. So one interesting thing I kind of saw immediately was that there is something in common between autism and comorbids, so because the numbers are high. And when I looked at overall how much of the demand they're meeting with the current research, they're actually only managing 61% of their demand. So their backlog is growing by 2 every day. So in 1 year, you're going to have 397. So that's kind of the message. But there's something interesting between autism and comorbids. So when I then looked at staffing, who is actually delivering autism and comorbid? So it's either lead clinician, any, which means lead clinician, non-comorbid, or lead clinician, both, and second assessor both. And here it's lead clinician both and second assessor both. So if I, for example, increase lead clinician both to 6 and run the model and see what happens there. Sorry, that takes a bit of time to run. Not too bad. So you can see that this didn't actually produce much change. So this wasn't really my bottleneck here. So I'm going to go back here. The other common thing here was that the second assessor both, they're delivering both appointments for autism and comorbids. If I increase second assessor both to 3 and run the model and see what happens then. So remember, our waiting time was in hundreds of days. And I'm just going to look at what happens if I increase the second assessor both. So this is now the waiting time split again in days, but it's down to, the whole waiting time is down to, 20, 40, 60. I do have here statistics about the median waiting time and so on. So you can see that by recruiting just one second assessor both, it reduces dramatically the waiting time. However, so you see also they are managing 99% of the demand by this, by only recruiting one resource. However, ADHD is still quite high here in number of days. So if I increase ADHD, second assessor ADHD, and run the model, then I can also look at the waiting time and compare it. I should learn to talk while it's running. Right. This is now down as well. So even though they were managing the demand, even with that previous resource with 3 second assessors both, the ADHD waiting time was still high. Now they're all very low. So this is what is shown by managing the existing demand. There's obviously still the backlog. Just wanted to summarize what we just saw, because I think it's more dramatic when you see it this way. So by recruiting a second assessor both, previously they managed, with the existing resource, they managed 61% only. By recruiting a second assessor, they're managing 99%. The waiting time overall, was in, I think median was about 300 or so, which is down in tens by recruiting second assessor. So that's the question around existing demand. Now, in addition to maintaining that steady state, how do we eliminate the backlog that has developed? So again, I'm gonna go back to the demo. So I'm gonna here include a clear backlog of 2,470 patients in 5 years. If I run it with the one that was great for steady state, and see what happens there. And I don't actually have two screens because I want it on the other screen to actually. So again, with introducing the backlog, they are managing only 58% with that resource. I actually identify what resources needed in order to manage it in 5 years, the backlog, to reduce the backlog. So it's 52544 is one of the options. 52544. Run that. But what I wanted to highlight here is that there are possibly different combinations that would help to reduce the backlog, and I would like to let services decide what the best way for them would be, because recruiting someone long-term or short-term, and it might be that different decisions might be taken place if you take into that into consideration. So we're providing a tool for the services to decide what's best going forward to recruit. So this is one of the options to reduce the backlog here. So I kind of wanted to go to the main challenges. So the main challenges in this project were actually not so much the technical side, but more mapping out the whole pathway. And it was, I think, mostly due to the lack of clear documentation and obviously staff and process changes and who does what, and different people do different things in the whole process. So it was also surprising to see that several sections of the pathway are not recorded in the main clinical systems, but rather in Excel spreadsheets. And then there were also a significant amount of incomplete data, which we had to deal with. So next steps, the findings and the model has been presented to the stakeholders, including service managers, clinical and operational leads, service heads, and the trust board. And discussions are already taking plans on how the model is used to support any improvement work in the service. It's worth noting that the current model is developed based on Oxfordshire NDC pathway. We are now looking into if we can implement a similar model with the Buckinghamshire pathway as well. And the tool is available to use as well to everyone. Thank you.